Hi, everyone. All right, I'll go ahead and get started. So my name is Rachel. I'm a very recent, 1 week ago today, graduate of this program. I'm really happy to be joining you virtually from Philadelphia, where I'm about to start on Tuesday my medical residency in combined internal medicine and pediatrics. I finished my PhD in anthropology last year, and I'm going to be presenting some of the work I did for my dissertation. My talk today is titled Evidencing Good Care, an Ethnographic Exploration of Validation, Certainty, and Communicability. Some of you have definitely seen me present on this project before, but my talk today focuses on just a slightly different aspect of it that I'm hoping to submit a paper about. So since this is a work in progress, I'm really looking forward to hearing your questions and feedback at the end. So please don't be shy. So I'm going to start with just some background describing my project, introduce the theoretical background I'm using for this talk, and then share a little bit of my ethnographic data. So in his 1995 address to the American Pain Society, James Campbell, who was the society's president at the time, introduced for the first time this idea that pain should be treated as the fifth vital sign. This idea was rapidly adopted across many healthcare systems and is now a standard part of medical education, at least in the United States. From the late 1990s, after this was introduced, to the early 2000s, a combination of advocacy work by pain experts, aggressive marketing by pharmaceutical companies, and recommendations from national organizations led to massive increases in opioid prescriptions, which unfortunately accelerated the tragedy of the opioid epidemic. However, a 2006 chart review study of the VA, where pain as the fifth vital sign was adopted in 1999, showed no measurable benefit in pain treatment before and after the policy began. So this has had a little bit of a mixed result, both on the patient level and on our national healthcare level, but still, anyone who's been to the doctor's office or the hospital in the United States in the past 25 years is super familiar with this classic 0 through 10 pain scale, which is formally known as the numerical rating scale. And what I'm showing on the slide here is called the Wong-Baker Faces scale, which is really commonly used in pediatrics. So it augments the numbers with illustrations here, which depict faces ranging from smiling to crying in pain. But the motivation behind my dissertation work is what happens with children, or adults for that matter, who can't indicate their choice on this scale because of a communicative impairment. So one form that is designed to address this issue is called the DISSTAT, the Distress and Discomfort Assessment Tool. On this slide, I'm just showing actually a very short excerpt of the form. It's quite a long and detailed form. You can see this is the section on facial signs, but the form also includes descriptions of body observations, vocal sound, habits and mannerisms, and so on. The idea behind this form is that one or more caregivers who know the person best fill out the form just one time to have it as a clinical reference that will travel with the patient between clinical settings. The DISSTAT stands in contrast with the Wong-Baker Faces pain rating scale, which we just showed, or other scales, because those scales tend to be, first of all, one-time measurements. They're also quantitative or numerical, and also the person has to typically be able to communicate their choice. Another big difference, which I'll get to in a couple slides, between the DISSTAT and other pain tools or tools in general, is that the DISSTAT is specifically a distress tool. So it doesn't call itself a pain tool. And I'll come back to this topic. So the DISSTAT was invented or developed in the UK in an adult population in a healthcare setting that used paper charts inside of a publicly funded healthcare system. The team that I worked with for my dissertation research was bringing the form to the US to work with children using an electronic medical record in a private, technically nonprofit, but very corporatized healthcare system. So this was a very big shift, and the powers that be determined that the DISSTAT would have to be validated again in this new setting and population before it would be permissible to use it in their electronic healthcare record. I'll talk about this more on the next slide and later on in the presentation, but this validation project became a primary goal of the clinical team that I followed in my research. Within the internal logic of the regime of validation, this request makes sense. because of these big shifts in the population that the form is going to be used with. But as I hope to argue in this talk, most efforts to validate any numerical pain scale are poorly done and maybe even fundamentally misguided. I don't think I have time for this slide, but I can talk about it in the Q&A if we have time. Just briefly in terms of my methods. So as I mentioned, there was an implementation project of the DISTAT at my field site. I joined the team in late 2019, early 2020, and my dissertation research had 3 parts. So my work as a member of the clinical implementation team was kind of classic participant observation, which means I was observing the team. So I was attending their meetings, taking notes, and then I was simultaneously participating and working with them to advance their goals, specifically for the purposes of this presentation, the validation project. Then another main aspect of my research was a combination of semi-structured interviews I did with parents and other caregivers of children. And then I also did content analysis of DISTATs that they completed. And these data both served to produce an ethnography and an anthropological dissertation, so my dissertation, and also produce this validation of the DISTAT form, which I'll come back to. And then finally, I also did a creative photo autoethnography about disability and communication, which I don't have time to talk about today, but it was actually just published as a chapter in an edited volume. So I included the link there and a QR code if anyone wants to check it out. So these are all kind of classic anthropological research methods. And just in the context of this symposium, I really want to highlight the benefits that my dual training in both medicine and anthropology brought to this project. I was able to integrate much more quickly into this clinical team and understand a lot more of the types of shorthand and the language overall that they use, just because I had done a little over a year of clinical rotations as a medical student before starting this research project. And in addition, for the ethnographic work I did specifically with parents and caregivers, I had much better access in terms of both like physical access to the hospital, but also just knowing how to communicate with nurses and other staff who were working with the patients or who were like generally around when I was coming in to work on my research. I don't want to get too heavily into theory, but there's a few concepts that influenced me a lot that I want to share. So Josh Reno, who is actually one of my committee members, offers this concept called home signs. This is a term that he uses for communicative acts that have distinct meaning to people who share intimate, caring spaces. As he writes in his book, quote, "To see a specific action as a home sign means taking an alternative gamble, to adopt a stance toward other people as capable of creative and intentional communication," unquote. So to me, this is a lot of what the DISTAT offers. So unlike other tools that use generic cues to allow anyone equal access to someone else's internal state, the DISTAT is much more of a work of translation, and it specifically valorizes the knowledge of a person's closest caregivers. And it allows this knowledge to then be legible to strangers and specifically to medical professionals who are strangers to the person. The provocation to assume that communication is intentional and 2 ways has really shaped how I think about this project. Another person whose work I've really leaned on when thinking about pain treatment has been Scott Stonington. He's written a lot about pain, and he describes what he calls the emergency affect of pain, which is the idea that pain produces this sense of urgency that is not only felt by patients, but is actually shared by their providers. So he asks, quote, "What if clinicians not only seek to palliate their patient's pain, but also their own discomfort with pain and the fraught negotiations that it engenders," unquote. So as one of his interlocutors pointed out, quote, "If we want there to be no pain, we suffer endlessly trying to make it disappear, to achieve the impossible. That is addiction, and it is not limited to patients. We doctors are uncomfortable seeing pain, and we want 0 out of 10 for our patients. We are part of it," unquote. So this obsession, especially in Western medical settings, with eliminating pain, with not having to deal with that emotional pull that a patient's pain can have, I would argue is very tied up with this desire to optimally quantify and measure pain using pain tools, because the only way that you can prove that you've eliminated someone's pain is if you have this perfected way of measuring it, and that perfection is achieved through validation. So a textbook definition of validation is the idea that a measure should have validity, describing what it is intended to measure and accurately reflecting the concept. I don't want to get too much into statistics, but if you've taken any classes in the past, you might recall that there's like levels of validity. So there's internal validity, external validity, and ecological validity. So one tells you whether you ran your experiment well, but the others tell you whether that actually applies to people outside of your experiment and whether it might be useful and meaningful in real-world situations. In medical research, the traditional way of validating a new tool is to compare it to existing quote-unquote gold standard tools. But before I get into my ethnographic data, which those kind of question the ecological validity of these tools, I want to ask if it is even a feasible goal to measure pain in a standardized way. But I want to look more closely at a couple of validated tools and talk about how even pain scales that are considered validated are not always accomplishing what they are purported to accomplish. So the DISTAT is not the first pain or distress measurement tool for this population, actually. There's several others, and one that's popular is called the Non-Communicating Children's Pain Checklist. And this scale is considered to be validated. So similarly to the DISTAT, it measures behavior across multiple domains. And I highlighted some of them here. But what I wanted to flag with these excerpts that I pulled is that in many cases, two opposite actions or behaviors can both be counted as demonstrations of pain. So for example, here under activity, both not moving or being less active, as well as being very active or agitated, are counted up to this quantitative total of the pain score. And similarly with body postures, either being floppy or being stiff, spastic, tense, or rigid, either one is counted towards pain. And this is an issue because having these opposite actions or behaviors quantified as pain makes it more likely that someone will qualify as being in severe pain kind of no matter what, especially if those behaviors represent their baseline. Many children who are non-speaking have coexisting medical conditions or neurological conditions that would cause them to just inhabit one of these ways of being at baseline, even if they're not having any pain or distress. And so the risk here is that behavior that either might just be a manifestation of their baseline habitus, or it could be a sign of some non-pain form of distress, would be quantified by this scale, would be reach the threshold of being pain, and then that child would be inappropriately treated, either with opioids or some other type of pain medication. And you can clearly see how this tool could have unintended and potentially negative consequences if used as directed, yet it was able to pass the statistical test to be considered validated. I want to do another case study to dig into the validation process itself and show how it can be used in misleading or actually just inaccurate ways. So I'm going to talk about a related form that was developed not for children, but for older adults with advanced dementia. So this tool, as the title suggests, specifically claims to measure pain. And it was validated against a prior tool, so the gold standard method that I mentioned on the previous slide. And the p-value that they found was less than 0.001, which sounds great, obviously statistically significant. However, if you actually dig up that first tool's validation paper, so the tool that their gold standard, it was explicitly designed as measuring discomfort, which those original authors defined as a negative emotional and or physical state, subject to variation in magnitude in response to internal or environmental conditions. So they did not claim that their tool measured pain, but when the Pain AD authors used their tool for comparison in their validation, they concluded that their own tool was validated in pain specifically. I would argue that this is at best a type of performative utterance rather than a scientific finding, but at worst could be considered pretty deceptive. And in addition, an independent study that was done years later on the Pain AD compared the way it measured pain versus non-pain distress, so distress from something other than pain. And these authors found that it had a sensitivity of 92%, but a specificity of only 62% for pain. Essentially, to translate that, there were more false positive identifications of pain than true positive. So within the study that was performed, the Pain AD more frequently falsely identified non-pain distress as pain than it actually was able to accurately identify pain as such. The authors in this second study, which is a group that actually includes the original developers of the DISDAT, posited that this is not specific to the pain AD, and it's actually likely a trait shared by many, if not all, other tools that are purportedly pain tools. The issues on this slide combined trouble the idea that the current model of validation has any real-world validity or use when applied to pain tools. As much as I've critiqued the validation process here, as I mentioned on a previous slide, the team with which I did my participant observation was required by its very data-driven corporatized healthcare system to produce a validation in order to be allowed to implement the DISDAT in their electronic medical record. So instead of comparing the DISDAT to any gold standard, we performed a much more qualitative version of a validation. I won't spend too much time talking about this study here, but we showed that caregivers could robustly identify a large number of cues. And in addition, even caregivers that found that the tool might be difficult to use or they weren't sure how difficult it was to use, still 100% of those interlocutors identified it as useful or helpful. And we were able to get these results published in a nursing journal, which was, for my team, the biggest hurdle for them to be able to implement this tool in the electronic medical record. There's actually still a lot of bureaucratic barriers left, which would be the subject of a whole other talk. I do think that this validation study that we did does have value in that it allowed the team to get the stamp of approval that they needed. But I would like to pose the question of whether that hurdle is artificially imposed and what benefit it actually offers to patients, like to do this research and publish it, given the prior discussion of the usefulness and validity of like validation studies of pain or distress, discomfort tools. So leaving behind validation, I would like to contrast this desire for and like fundamental belief in quantitative certainty around patients' pain that these efforts at validation represent with some parent narratives that I'll share from my fieldwork. I'm going to touch on them very briefly since I only have a few minutes left, but I wanted to just highlight that while these parents do share a similar emotional desire for certainty around their children's pain and distress that clinicians and researchers have, they don't necessarily believe that reaching certainty is possible. So these excerpts I'm about to share, as well as other data from my interviews, also show an obvious deep love and profound communication with their children. The individualized home signs that they collaboratively learn and develop are the best way that they can see of reaching understanding of their children's pain and distress, in contrast with the standardized universal tools that, for better or for worse, characterize the same behaviors as representing pain in every patient. So I'll just kind of skip through these, honestly, and we can come back, but this is a patient, a mother talking about her daughter, and she highlighted how, she would videotape her to try to see her signs of pain, but she had trouble in the moment. And, it's really hard for her to know when she's in pain. And a recent incident where she had cried after she stubbed her toe was like one of the first times that she showed like a very obvious pain reaction. This next one similarly talks about like they can tell that there's discomfort, but figuring out whether that is pain or irritability, where pain would be located is really difficult because of their child's communicative impairment. And it's this like experiment over time, like learning process that they go through. Here's another parent, very similar statement, just talking about how it's hard to know what is upsetting their child because, kind of like anyone, even people with typical communicative behaviors, like when we're in pain or distress, our level of communication can go down. We're not as able to articulate what's going on. And that can make, even if you have a way to communicate in these moments of crisis, it can get more difficult. So I'm not really going to have grand conclusions, but just to finish with some concluding questions. Measurement and evidence are obviously central to the project of biomedicine, as is the goal of alleviating pain. but what counts as evidence when you're looking at someone else's pain? What does a gold standard mean? It's not the same as having a gold standard for like measuring the level of sodium in someone's blood or something that like exists in a quantitative way outside of the person's body and mind. Even when a so-called gold standard is replicated, as this presentation showed, there's flaws in the scientific process when it comes to pain and a lot of holes in this chain of evidence. And then what makes a tool valid? So thinking again about this idea of ecological validity, that real world type of validity, just having a tool that's, quote unquote, proven with this great p-value doesn't necessarily mean that it's going to lead people to get better care. And that, I would argue, is more important. I think a lot about Sarah Ahmed, who writes about the ungraspability of the pain of others. So she writes, the ungraspability of my own pain is brought to the surface by the ungraspability of the pain of others. So this type of phenomenological analysis that Sarah Ahmed offers raises this question for me of whether any person's pain, so regardless of their level of disability or communicative abilities, can be quantified successfully in a standardized manner, or does the standardization cause important details to be lost in a way that can render it either meaningless or even actively harmful? So I want to thank a lot of people. Specifically, I want to thank the Center for Social Medicine, as well as everyone listed on this slide. Also, all of my interlocutors from my dissertation and all my colleagues in the program. Many of you are in the room, I think, who have supported me during this very long journey. And yeah, as I mentioned, this is a work in progress. I would really love to hear what you all think. Thank you so much for listening, and please feel free to reach out via email with any questions or comments.
We do have time for questions.
Yeah, that's good.
All right. Questions?
So, Rachel, that was very moving and powerful. And I wanted to ask about the first, I guess, among other things, the first slide about the narratives of parents. As I remember from your dissertation, there were also a significant number of children coming to the clinic who were being taken care of by the state, I think. And I don't know if one can understand the parents who don't talk about their children or don't deal with their children as in a way to care about their pain or to be able to talk to people about their pain.
Yeah, that's a great question. Oh, sorry to interrupt.
Sorry, no. Is there a space for ambivalence and denial or abandonment or something else, more fallibility, I guess?
Yeah, I think that came up a lot, honestly, even with parents who live with their children and have full custody of their children, just because a lot of the medical staff would argue, like, when these children are in a moment of crisis, when they're hospitalized, they're not acting like themselves. They're not being their normal selves, which did kind of come up in the interviews with parents as well. But, they kind of argue like, well, we know best because we know sick kids and how sick kids act. I do think in some ways it is like a strength of the DISSTAT form that it's designed to be filled out by potentially multiple caregivers. So I think like the long-term care facility that my team worked with had this idea that like, multiple staff members who see the child every day would fill out the form, and the parents would be invited to fill out the form as well. And just having more cues identified would improve the utility of the form. I didn't end up doing as much work with those patients during my actual dissertation work, partially because it's just like then very hard to get consent in those situations. But yeah, I think it's really tough, but I think, using a scale or a tool that takes a broader view of who is an expert and who has like a valid information about a child to offer would help address that issue.
You can see you. Go ahead.
Thanks, Rachel. That was wonderful, as always, interesting. I'm interested in the problems of validation that you're presenting here, and wondering if you could speak a bit more about what those the stakes of the flaws are, so to speak. In other words, there seemed to be some confusion or ambiguity between pain and irritability and distress or discomfort. And I can imagine, but I don't know, that it is important to distinguish between those, among those different alternatives, partly because perhaps you wouldn't be medicating in the same way, right? So I'm just wondering if you could talk a little bit more about that issue. And then the second issue that I was curious about was sort of where you ended in saying that, is the problem validation or is the problem standardization? Kind of between those two poles, I see some interesting questions, because in your ending, talking about standardization, one of the problems is that, we need to be sensitive to the context and the individual and the moment and everything else. But how does that then circle back to the validation question? Anyway, any of those questions. Thank you.
Yeah, no, those are great questions. So the problems with non-pain distress, so even the parents would identify a lot of examples of like non-pain distress that their children would show. So, something like urinary retention, if you're not able to pee and your bladder gets really distended, like it's not necessarily a pain that should be treated with like opioid medication, but if you give someone a ton of opioids, like they will stop complaining typically about whatever is actually causing their distress. So it's very hard to measure like when you're making that mistake. And then other things, one patient that I worked with had like respiratory distress, so trouble breathing, and that would be interpreted as potentially pain. And opioids will obviously like make that worse. Like they'll make the person seem less distressed, but if they're having actual like trouble oxygenating, it'll make it much worse. So there are like big stakes to getting it wrong, but then also you don't always find out when you got it wrong. And then I think in terms of the standardization, that is something I have to think about a lot, but I guess how it relates to the validation is that both of these things are like hurdles to implementing the form in a technocratic type of system, right? So it's, first of all, it has to be considered validated, and that was this big hurdle for the team, but then also something that's non-standard and is like a little different for every patient. We have all this qualitative data saying like people like that much more and it probably works better, but then the checklist fits with the model of the electronic healthcare system and the standardization of healthcare that we're trying to do. So it's a little bit like against the culture or against the grain of how healthcare systems work today. And so I think a lot of like our validation project was just trying to like speak that language, but still do this qualitative assessment of the tool.
Just ask. Like that's what a lot of these projects do, Rachel, is like trying to speak the language of the systems, right? But still hear the voices of the people who are in them. Thanks a lot.
Do we have any
Thank
more?
you.
We don't.